The broadcast is now starting. All attendees are in listen-only mode.
Welcome everyone to today's webinar. Before we begin, I would like to go over a few items so you know how to participate in this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and the audio pin. All audio will be muted, and at the end of today's presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. The presenters will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. I would now like to introduce today's moderator, Dr. Gary Raskob, PhD. Dr. Raskob serves as Dean and Regents Professor of the College of Public Health at the University of Oklahoma Health Sciences Center. He also chairs the World Thrombosis Day Steering Committee. Dr. Raskob, welcome.
Thank you very much, and welcome everyone. This webinar series is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. It's my privilege to moderate today's webinar on the critical public health topic of venous thromboembolism. We know that VTE is now a leading cause of death and disability worldwide, and particularly death and disability associated with a hospital stay. We're very fortunate to have a true expert in the field who will share cutting-edge information on how to best understand and manage the risk of venous thromboembolism in surgical patients. Before we begin today's presentation, we would like to learn a little more about our audience. We will begin with an audience poll. The poll question should appear on your screen. Please elect your primary professional role now. And we'll give a few minutes to people to answer the poll. It's very helpful to us to have this information so we know how to plan and organize for future educational activities, so we appreciate your response. I think we can go ahead and now close the poll. Thank you. So we see that we have 78% of healthcare professionals here, and then distributed amongst the other ranges, and it's good to have some industry partners and our consumer advocates as well. Thank you for joining very much. It's now my pleasure to introduce today's presenter, Dr. Michael Cassidy. Dr. Cassidy is a surgical oncologist and assistant professor of surgery at Boston University School of Medicine. After earning his Doctor of Medicine degree at Boston University, he completed residency in general surgery at the Boston University Medical Center, and then followed that with a research fellowship in quality improvement and patient safety. It's very relevant to the area of VTE. Following residency, he completed a clinical fellowship in complex general surgical oncology at Memorial Sloan Kettering Cancer Center. His clinical practice focuses on the care of patients with breast cancer, sarcoma, melanoma, and gastric cancer. His research efforts are dedicated to surgical quality improvement and reduction in adverse postoperative events. In particular, he has authored studies on standardized postoperative risk assessment programs and on prevention protocols for postoperative pulmonary complications and venous thromboembolism. These important studies have been published in key peer-reviewed journals, including JAMA Surgery, the Journal of the American College of Surgeons Surgery, and the Journal of Surgical Research. Dr. Cassidy, welcome. Thank you for participating and giving the webinar today, and we hand over to you to begin the presentation.
All right, thank you, Dr. Raskob, and thank you to the organizers, the Division of Blood Disorders at the CDC and the National Blood Clot Alliance for inviting me to participate in today's webinar. It's really an honor to join you today. I have no disclosures. So in today's webinar, I will discuss perioperative VTE risk assessment and prophylaxis. And as an outline, I'll talk about the problem of venous thromboembolism, various prophylaxis options and the evidence for their use, personalized VTE risk assessment methods, barriers to adequate prophylaxis, strategies to improve prophylaxis. Our experience at Boston Medical Center with the development and implementation of a standardized VTE risk assessment and prophylaxis protocol, the problem of prophylaxis failures, and finally, future goals for work on this topic. So venous thromboembolism events, which can include deep venous thromboses and pulmonary emboli, are a leading cause of morbidity and mortality among patients in the United States, with an estimated annual incidence of approximately 900,000 cases. Symptomatic VTE occurs in 0.4 to 6% of postoperative patients, and these events can cause sudden death, reduced survival, pulmonary hypertension, and venous hypertension that can lead to post-thrombotic syndrome, which is characterized by debilitating swelling and chronic pain. One study estimated the attributable cost of a VTE complication to be over $18,000, while increasing the average hospital length of stay by 15 days. Postoperative patients are at or particular risk for VTE as major operations induce an inflammatory response and a hypercoagulable state and create an endothelial vascular insult. Furthermore, the tendency for postoperative patients to limit mobilization due to pain may predispose to venous stasis. There are multiple options for VTE prophylaxis that are widely accepted. And broadly, the categories of prophylaxis include mechanical prophylaxis and pharmacologic prophylaxis. It's generally accepted that mechanical prophylaxis, such as intermittent pneumatic compression, is an effective and low-risk strategy to reduce VTE in postoperative patients. And anticoagulant medications as pharmacologic prophylaxis have been extensively studied in terms of their safety and efficacy in surgical patients. This meta-analysis assessed whether intermittent pneumatic compression of the lower extremities was effective in prevention of venous thromboembolism and found that intermittent compression reduced the incidence of both DVT and PE. A combination of intermittent pneumatic compression with pharmacologic prophylaxis provided even more effective risk reduction. This meta-analysis of randomized trials of prophylactic dose subcutaneous unfractionated heparin was published in the New England Journal of Medicine and included general surgery, orthopedic surgery, and urologic surgery patients. The study showed that low-dose unfractionated heparin reduced the likelihood of a DVT event with a relative risk reduction between 67 and 75%. It also reduced the incidence of both fatal and non-fatal pulmonary emboli, and there was no increased risk of fatal bleeding in these patients. And this meta-analysis in the British Journal of Surgery reviews trials of low molecular weight heparin, such as enoxaparin, for VTE prophylaxis. Compared to no prophylaxis, low molecular weight heparin statistically reduces the incidence of both symptomatic and asymptomatic VTE events and reduces fatal events, although that comparison does not reach statistical significance. There was an increased risk of postoperative bleeding in patients who received low molecular weight heparin. And compared to low-dose unfractionated heparin, low molecular weight heparin is largely considered equivalently effective for VTE prophylaxis in most surgical populations, except for in some special scenarios that I will discuss a little bit later. So we know that surgical patients are at increased risk for VTE events and that effective prophylaxis exists, but prophylaxis may also have associated risks, including bleeding. And we also know that the risk of VTE events varies between patients, and it becomes especially important to understand VTE risk assessment to most appropriately weigh the risks and the benefits of VTE prophylaxis for every surgery patient. With that in mind, there are two general ways to conceptualize VTE risk assessment. The first one is group risk assessment, and that is to categorize patients into broad target groups based largely on the level of risk conferred by their operation. And this is the system that was recommended by the widely accepted American College of Chest Physicians 8th edition guidelines. So by group risk assessment, patient risk is considered based on the risk of their operation. Minor surgery in ambulatory patients is considered low risk for VTE. Most abdominal surgery is considered moderate risk, and major trauma, spinal cord injuries, some orthopedic surgery is considered high risk for VTE. And these basic risk tiers can inform prophylaxis choices as specified in the guidelines. And while group risk assessment is a good starting point when considering VTE risk, it does not really account for the many recognized risk factors for VTE that are conferred by the patient's individual factors, comorbidities, and medical history. Some of the known patient-level risk factors are listed here, and these include variables such as patient's age, mobility status, obesity, personal or family history of VTE, pregnancy, varicose veins, etc. There are also medical and surgical factors as shown, which include type of operation, but also factors such as cancer history, inflammatory bowel disease, MI, stroke, fractures, and others. We also have to consider recognized hypercoagulable states, which clearly confer higher risk to patients. So all of these factors contribute to an individual patient's level of VTE risk. Therefore, individual risk assessment is a way to account for these factors and to calculate a weighted numeric score that can provide a more refined risk estimate for each patient. And one system for characterizing individual risk is the Caprini Score. The Caprini System recognizes that numerous factors confer differing degrees of hazards for VTE and assigns relative values to those attributes to derive an estimate of VTE likelihood. The numerical score is assigned, which places patients into risk categories. The score is well validated and has been shown to accurately predict the chances of VTE in surgery patients, and it has guided prophylaxis decisions. In the Caprini System, VTE risk factors are assigned a numeric value ranging from 1 to 5. The values of each risk factor present are added up to provide a total score that places the patient into a risk category. The Caprini System has been well validated in several surgical populations and has been shown to reliably predict the risk of VTE. This paper is from the University of Michigan and validates the incidence of VTE stratified by the Caprini Score, both for the risk categories in general and for the numeric values. The Caprini Score has also been validated in critically ill surgical patients, as shown here, with calculated scores correlating to the observed incidence of VTE. I mentioned previously that the 8th edition of the American College of Chest Physician Guidelines is largely based on group risk assessment, and the more recent 9th edition of the chest guidelines incorporates the Caprini Score as a method of individualized risk assessment that can be used as a basis for making clinical decisions regarding prophylaxis regimen. The chest guidelines also provide risk-based recommendations for prophylaxis, which include either no prophylaxis or mechanical prophylaxis alone for low-risk groups, and low molecular weight heparin or low-dose unfractionated heparin combined with mechanical prophylaxis for higher-risk patients. For high-risk cancer surgery patients, extended duration prophylaxis is recommended, and for patients with a high risk of bleeding, mechanical prophylaxis alone is recommended. When pharmacologic prophylaxis decisions are being made, the VTE risk factors are also considered in light of known risk factors for bleeding, which I have listed. So cancer patients are a population that deserves special mention because we know that cancer is a major risk factor for VTE, and these patients require additional consideration. Cancer alone is associated with a 4-fold increase in the risk of VTE, and the administration of chemotherapy is associated with a 6-fold increase in the risk of VTE. When do VTE events occur in cancer surgery patients? That question was answered in this analysis of the National Surgical Quality Improvement Program database, which included over 44,000 patients with any one of 9 cancer diagnoses who underwent surgery. The authors found that up to about 1/3 of VTE events in cancer surgery patients occur after discharge from the hospital. This graph shows the timing of VTE events stratified by cancer site, and you'll notice that cancers that typically have shorter hospital stays, for example, endocrine and breast cancer patients, have higher rates of post-discharge VTE. The authors also found that mortality rates were significantly higher in patients who had VTE events when compared with those that did not across the multiple cancer types. So we know that a significant number of cancer patients experience VTE events after discharge, but the majority of patients only receive VTE prophylaxis during hospitalization. And if we know that cancer patients have a high likelihood of post-discharge VTE, could extended duration prophylaxis be helpful? In this randomized trial published in the New England Journal of Medicine, cancer surgery patients all received enoxaparin VTE prophylaxis while admitted and were then randomized to receive an additional 21 days of enoxaparin or placebo. Patients were evaluated by venography at the conclusion of the study period. And the authors found that extended duration enoxaparin significantly reduced VTE events in cancer surgery patients when compared to prophylaxis that was administered only in the inpatient setting. They also found that the incidence of bleeding was no different, showing that extended duration prophylaxis does not increase the risk of postoperative bleeding compared to standard inpatient course prophylaxis. Another randomized trial of 7 versus 28 days of dalteparin in major abdominal surgery was conducted as a multi-center trial, and this showed a reduction in the rate of VTE events in patients who received extended duration prophylaxis. So these studies make a strong argument for considering extended duration pharmacologic prophylaxis, particularly in cancer surgery patients. Moving on to trauma patients, we know that major trauma is another significant risk factor for VTE. And in this trial in the New England Journal of Medicine, randomized trauma patients to either low-dose unfractionated heparin or to enoxaparin dosed at 30 milligrams twice daily. And notably, the standard prophylactic dose of enoxaparin is 40 milligrams once a day. The authors found that a statistically significant reduction in VTE events occurred with enoxaparin 30 milligrams given twice per day as compared to low-dose unfractionated heparin, and this establishes enoxaparin 30 milligrams twice a day as the preferred prophylaxis regimen in major trauma patients. So data from multiple randomized trials and meta-analyses have proven the efficacy of VTE prophylaxis for surgery patients, but how often is VTE prophylaxis actually being used, and how often is it being appropriately used? This multinational study asks those questions. The authors evaluated 68,000 patients and determined VTE risk and adherence to the chest physician's prophylaxis guidelines. The study includes medical and surgical patients, but I'll focus on the surgical population. Among surgical patients, only 55% received pharmacologic prophylaxis, and 36% of patients received no prophylaxis at all. This similar study looks at adherence to the chest guidelines in US surgical patients stratified by surgical discipline. In all surgical patients, 77% received some prophylaxis, but only 16% were considered to receive prophylaxis adhering to the guidelines. The reasons for inappropriate prophylaxis were inappropriate dose, insufficient duration, receiving mechanical prophylaxis only, or having no prophylaxis ordered at all. If so few surgery patients are receiving appropriate prophylaxis, what are some strategies to improve prophylaxis? Many quality improvement efforts have been described, and these have included passive dissemination, meaning simply distributing recommendations to healthcare providers. Other strategies include audits of performance with feedback, documentation aids, computer-based decision aids, and educational activities. An analysis of these strategies shows that passive dissemination is generally not effective. If a single strategy is to be used, computer-based decision aids seem to be the most effective, but using multiple active strategies together is the most likely to result in optimal practice. This is a randomized trial of electronic alerts to prevent VTE that was published in the New England Journal of Medicine. Patients were randomized to an intervention group for which physicians received electronic alerts of the patient's VTE risks, or to a control group for whom no electronic alerts were generated. The choice of prophylaxis was at the physician's discretion. They found that patients in the intervention group were more likely to receive prophylaxis, and that patients in the intervention group were statistically less likely to have a VTE event over the study period, as shown here. So now I will move on to talk about how we use some of these concepts to develop a standardized perioperative VTE risk assessment and risk stratified prophylaxis program at our hospital in Boston. Just to give a sense of the environment in which we developed this system, our hospital is Boston Medical Center, which is a merged entity of the former Boston City Hospital and Boston University Hospitals. It is an urban academic safety net medical center with 487 beds. About a quarter of our patients do not speak English, and racial and ethnic minorities constitute the majority of patients. Half of our patients have an annual income below $20,000. In 2009, a review of our National Surgical Quality Improvement Program data revealed that our medical center was a high outlier for VTE in general surgery and vascular surgery. This is a caterpillar graph in which each vertical line represents a single hospital enrolled in NISQIP and shows each hospital's odd to expected ratio, which is a risk-adjusted measure of outcomes. High odd to expected ratios indicate a higher number of adverse events than expected, and these are the hospitals on the right side of the graph. And as you can see, our odds to expected ratio for VTE was 3.41, far to the right and a very far high outlier, suggesting an opportunity for improvement. Our objective was therefore to implement and to determine the efficacy of a standardized VTE prevention program. In response to a clear need for redirection of postoperative practices, a VTE working group convened, including representatives from multiple disciplines. We aimed to create a simple and standardized suite of VTE prevention guidelines. Our consensus was to include early and frequent patient mobilization, standardized risk assessment, and individualized risk-based prophylaxis with electronic automation as key components of our program. One element of our VTE prevention program is early and frequent postoperative mobilization, at least 3 times daily. As part of our effort, we educated patients and their families about mobilization by creating brochures, videos, and posters that were translated into multiple languages. Education of nurses, physicians, and staff was comprehensive and included meetings to provide data about our VTE performance and outcomes. To support physician efforts, we created standardized electronic order sets that provide specific mobilization instructions to be used for all general and vascular surgery patients. Now, we later received some criticism about this aspect of the program, as the actual evidence for ambulation as a VTE prevention strategy is weak. And there are certainly problems in measuring ambulation and in determining the dose of ambulation that is protective against VTE. However, we consider this as a component of good postoperative practice, even if difficult to strictly measure its impact. We combine the postoperative mobilization efforts with a mandatory standardized VTE risk assessment score based on the Caprini System. As I discussed earlier, the system recognizes that numerous factors confer differing degrees of hazards and assigns a numerical score to each, which is added to derive the patient's level of risk. We designed a system in which it became mandatory to calculate the Caprini score for every patient on the general and vascular surgery service. To ensure utilization of the risk assessment tool, we developed an electronic scoring system that was integrated with the inpatient medical record. When we first developed the system, we were using the Sunrise Clinical Manager program, and the system utilized a checkbox format so that each risk factor was listed and could be selected with a simple click. The risk score was then automatically calculated based upon the chosen risk factors. The electronic order system was customized to require that a Caprini score be calculated for every patient at the time of operation or admission within the general surgery and vascular surgery standardized order sets. If no Caprini score was calculated by the surgery team, the orders could not be completed. Therefore, we made an effort to ensure that each patient would be scored according to the Caprini model. We later changed our electronic medical record to EPIC, and we had to redevelop the mandatory scoring system to work within EPIC. This is a screenshot showing how the risk factors are selected in EPIC. The score can also be calculated multiple times throughout the patient's course. So for elective surgery patients, the score is first calculated in the pre-procedure clinic and then again after the patient undergoes an operation. For emergency surgery patients, the score is calculated by the surgical house staff when the patient is admitted. And if there are any changes to the risk factors during the hospitalization, the score is recalculated. Finally, the score is recalculated at discharge to determine the appropriate prophylaxis regimen. This screen shows an example of how we can review the Caprini scores at each time point for each patient if they change over the course of the operative and hospital course. We also created standardized VTE prophylaxis regimens and linked them to the Caprini risk categories. The prophylaxis regimens provide the recommended mechanical and pharmacologic prophylaxis along with a suggested duration. The duration may require continuing pharmacologic prophylaxis on an outpatient basis. For example, patients whose Caprini scores place them in the high-risk category are advised to receive at least a 7 to 10-day course of prophylaxis, which often requires outpatient administration. And patients in the highest risk group are advised to receive a 30-day extended course of chemoprophylaxis, including outpatient treatment. The risk assessment is integrated with the order sets so that the risk-appropriate prophylaxis is displayed when completing orders for the patients. If no prophylaxis is selected for reasons such as a contraindication or surgeon discretion, the reason is documented within the order set. And if no prophylaxis is selected at the time of admission, a 48-hour reminder is generated within Epic to suggest that reassessment of the appropriateness of prophylaxis should be performed. When the patient is discharged, a reminder is generated for patients at the high or highest risk categories, and this suggests the recommended duration of extended prophylaxis when appropriate. And finally, a discharge order set is provided within Epic to assist in prescribing extended course prophylaxis. In terms of adherence to the recommended prophylaxis recommendations, we performed a 6-month audit and observed that we had 100% adherence to the recommended prophylaxis regimens among patients who were stratified in the low risk and the moderate risk groups. Among patients in the high risk category, 89% received appropriate pharmacologic prophylaxis and duration. 10% of patients did not receive the recommended regimen based on surgeon discretion, and 1% of patients had a contraindication. Adherence to the recommended prophylaxis and duration was 77% for patients in the highest category, with 23% of those patients having contraindications to pharmacologic prophylaxis. No patients received inappropriate or inadequate prophylaxis without an electronically documented reason. And with implementation of our prevention efforts, we saw a fairly rapid and sustained decrease in the incidence of VTE events. The blue line represents our raw incidence of DVTs in general surgery and vascular surgery, which fell from 1.9% before the prevention program to 0.2% currently, which represents a 90% relative reduction in events. For comparison, shown in green is the incidence of DVTs at comparable NSQIP institutions, which we consider to be large academic medical centers, and this rate remained largely unchanged over time. We also saw improvements in the incidence of pulmonary embolism. Shown in blue, the raw incidence of PE at our institution was 1.1% before the prevention program, and it decreased to 0.1% over time after implementation of the protocol. In the most recent reporting period, we had no documented PEs amongst our patients. And again, for comparison, the outcomes at comparable NSQIP hospitals is shown in green. In terms of risk-adjusted data, our VTE odds ratio declined markedly from 3.4 before our program to 0.8 after its full implementation, indicating that we are now having fewer VTEs than would be expected based upon our patients' severities of illness. During this time, we have also seen our overall morbidity decrease due in part to these efforts. So we observed that our VTE risk assessment and prevention program has significantly reduced the incidence of VTE complications among our patients. Standardization has been a critical element of our success, and this includes both standardization of our postoperative mobilization guidelines and the mandatory standardized risk assessment and risk-based prophylaxis system. Further, the simplicity of the electronic risk assessment tool makes it easy to use for every patient. Automation of reminders for prophylaxis even after discharge has eliminated the likelihood of human error and oversight, and education has been a key component. And we published our experience in the Journal of the American College of Surgeons in 2014. We have faced some challenges, however. First, many patients at our safety net hospital were unable to afford outpatient low molecular weight heparin when prescribed. To address this problem, we reconvened the multidisciplinary VTE task force to focus on the affordability of the protocol. Our first objective was to perform a cost analysis of the different low molecular weight heparin options available within our purchasing contract to see which would be the most financially viable for the patients as well as for the hospital. And next, we aim to evaluate the cost effectiveness of the Caprini initiative from a broader hospital perspective in order to provide support for utilizing resources. We decided to switch the low molecular weight heparin on formulary from dalteparin to enoxaparin because of differences in their costs within our hospital's purchasing contract. While dalteparin had a lower inpatient cost, it had higher outpatient costs and co-payments for patients. In contrast, enoxaparin had higher inpatient costs, but significantly lower outpatient costs. While the switch to enoxaparin resulted in slightly higher costs for the inpatient pharmacy, it was outweighed by the overall greater financial benefit for our patients. And it's worth noting that these cost differences are likely not universal and will differ by institution depending on individual purchasing contracts. Then, in order to prove the value of the Caprini initiative, we performed a cost analysis. The blue bars in the graph show the estimated cost associated with both DVT and PE complications in the 2 years prior to implementation of the Caprini protocol, and the red bars show the decreased post-implementation VTE costs. The total amount of cost savings was estimated to be over $1.5 million based on the reduction in complications. So given the successful reduction in VTE complications and the associated hospital cost savings, many were convinced of the value of the program and the need to ensure equity in its benefits for all of our patients, even the ones who could not afford outpatient pharmacologic prophylaxis. So we were able to address the financial arrangements for patients who need outpatient low molecular weight heparin in a successful way. The next problem was in standardizing practice across all disciplines. Our protocol was initially adopted only by the general and vascular surgery services. Other surgical subspecialties were not as willing to use the protocol early in our experience. However, we felt that having a standardized practice across all surgical services would be important to ensure best practices for all patients. Over time, other surgical services began to appreciate the value of the standardized protocol, and it was later adopted by the plastic surgery, thoracic surgery, or urology, gynecology, orthopedic surgery, and neurosurgery services. And some of our surgical subspecialty colleagues have even published papers about their own experience validating our standardized system and monitoring outcomes in their own patient populations. This is a paper from our Department of Otolaryngology showing validation of the Caprini score in head and neck surgery patients. And this is a paper from our thoracic surgery group, again showing the predictive value of the Caprini score for evaluating VTE risk in esophagectomy patients. Our thoracic surgeons then published a follow-up paper in which they tracked their outcomes after implementing the Caprini system for their lung and esophageal cancer patients. And they showed a reduction in VTE events by using the risk assessment and prophylaxis model, although this did not reach statistical significance, perhaps because of the small size of the study. So going back to our data in general and vascular surgery, while we reduced the incidence of VTE, we could not reduce that incidence to 0 despite good adherence to the standardized protocol. So we then asked the question, why does VTE prophylaxis fail? It was already known that missed doses of pharmacologic prophylaxis are associated with increased risk of VTE, as shown in this paper, with higher numbers of missed doses associated with escalating VTE risk. Reasons for missed doses were sometimes documented, and these included pending procedures, patient absence from the room, bleeding concerns, epidural management, and human error. We decided to investigate our own prophylaxis failures to determine the characteristics of patients who develop VTE events despite the highly effective risk assessment and prophylaxis protocol. We performed a review of all non-trauma general surgery patients who developed a VTE since the implementation of the program and compared these to the larger population of patients who did not have VTE events using data from our institutional NSQIP database. We found that 27 total patients failed the VTE prophylaxis protocol over 4 years for an overall VTE rate of 0.3%. Of the patients who developed VTEs, 63% of them had had emergency operations, 52% of them underwent multiple operations during their hospitalization, 52% had perioperative sepsis, 22% had malignancies, but only 15% had missed one or more than one dose of pharmacologic prophylaxis. And the reason for that was often that the prophylaxis was due during one of their multiple operations. One patient had underestimation of the Caprini score due to a lack of awareness of a family history of VTE. So compared to patients who did not develop VTEs, shown in the blue bars, those who did develop VTEs were much more likely to have had emergency operations or multiple operations, as shown in the red bar. We published these findings also in the Journal of the American College of Surgeons, finding that emergency operations, multiple operations, and perioperative sepsis seem to confer dramatic hazards for VTE despite standardized risk stratified prophylaxis. These factors are not completely captured in the Caprini risk model, but may be significant modifiers of risk. And we were encouraged that most patients receive prophylaxis adhering to the protocol. We then set out to use the larger NSQIP database to validate our institutional findings on an international scale. This project was led by Stephanie Touloudis, who is one of our general surgery residents here in Boston. Stephanie evaluated the general surgery patients in the NSQIP participant use file from 2011 to 2015, paying particular attention to our previously identified high-risk factors for prophylaxis failure. Over 1.6 million patients were included in the analysis. The overall VTE rate was 0.8%, which is consistent with literature on the topic and historical NSQIP outcomes. Within this cohort, about 15% of patients had had emergency operations, 3% had had multiple operations during a hospitalization, and 10% had perioperative sepsis. The graph demonstrates that VTE rates are higher in patients with these high-risk factors when compared with patients who did not have the high-risk factors. Displayed in the table are the odds ratios of VTE for each of these high-risk factors. Patients with emergency operations had an odds ratio for VTE of 1.4. Those who had multiple operations had an odds ratio for VTE of 1.9, and those with perioperative sepsis had a 2.4 odds ratio of VTE. Dr. Touloudis then looked at the interaction of these variables to determine their cumulative effects using a multivariable logistic regression model. So the combination of perioperative sepsis and emergency operation produced an odds ratio of 2. Emergency operations and multiple operations produced an odds ratio of 2.3. Perioperative sepsis and multiple operations produced an odds ratio of 2.5. And those with all three high-risk factors were found to have an odds ratio for VTE of 2.7. So we were able to validate our institutional findings on a much larger scale. Dr. Touloudis confirmed that VTE hazards are increased in those with emergency operations, multiple operations, and perioperative sepsis. And the next question is, how can we provide enhanced prophylaxis to the patients who are most likely to fail a standard prophylaxis protocol? There are some data, particularly in trauma surgery patients, that typical dosing of low molecular weight heparin is often subtherapeutic in high-risk patients. Therapeutic levels of enoxaparin can be monitored by measuring anti-factor Xa levels, as some authors have reported. This study from the University of Minnesota tracked anti-factor Xa levels in patients receiving enoxaparin for prophylaxis. They found that the initial anti-factor Xa levels were lower than the target in 72% of patients. In their population, they observed 4 VTE events, all in patients who had subtherapeutic anti-factor Xa levels. This study from UC Irvine showed that trauma dosing of enoxaparin at 30 milligrams twice a day leads to low anti-factor Xa levels in half of surgical ICU patients, and that low levels are associated with a significant increase in the risk of DVT. This study from Cedars-Sinai tested an enoxaparin dosing adjustment protocol where dose was adjusted based on anti-factor Xa levels. Low anti-factor Xa trough levels were followed by increase in the dose of enoxaparin by 10 milligram increments until goal levels were reached. And the authors found that found a decreased incidence of VTE in the dosing adjustment group as compared to a fixed dose group. The bar graph shows that the enoxaparin dose that was required to achieve therapeutic anti-factor Xa levels, and this ranged from the standard 30 milligrams twice a day up to 70 milligrams twice a day. And finally, this study from UC San Diego proposes a weight-based enoxaparin dosing strategy, and this resulted in improved rates of therapeutic anti-factor Xa levels. So the concept of enhanced prophylaxis and monitoring of anti-factor Xa levels is interesting, but it requires further study. Here in Boston, we felt that this concept could be applied to the risk groups that we have identified as being the most susceptible to fail standard VTE prophylaxis. That is, patients who have emergency operations, multiple operations, or perioperative sepsis. Our plan for the future is to build a system of electronic notifications for high-risk patients who would screen in if they met 2 of the 3 of these high-risk features. We would enroll these patients on an enhanced prophylaxis protocol with monitoring of anti-factor Xa levels and subsequent dose adjustment. We intend to track these outcomes over time and report this at a later date. So I will stop there, and to summarize, surgical patients are at increased risk for VTE events. Risk is conferred by both type of operation and patient comorbidities and risk factors. Individualized risk assessment provides refined estimates of VTE risk. Effective prophylaxis is available. Certain populations benefit from extended courses of prophylaxis. Risk commensurate prophylaxis regimens can be developed as an institutional protocol. Electronic automation in the electronic record reduces human error and increases adherence. A program combining mandatory risk assessment, risk-based prophylaxis, extended prophylaxis, and automation has reduced VTE events in our particular patients. Emergency operations, multiple operations, and perioperative sepsis confer increased risk for VTE despite administration of prophylaxis. And future work will aim to optimize and provide enhanced prophylaxis for patients who are at the highest risk for failure of standard prophylaxis. So I just want to acknowledge our quality improvement group here at Boston Medical Center. David McEnany is really the champion of this work, and he has been a mentor and a role model to myself and to many of us in the department. He has really supported our work in this area. Pam Rosencrans is a dedicated and very energetic quality improvement specialist who has a vital role in the development of our quality programs. Stephanie Touloudis and Ryan Mocht are 2 very bright and talented general surgery residents who have contributed to our VTE prevention work in meaningful ways, and they provided a lot of the data for this talk. And Dr. Caprini has provided some guidance to us as well, for which we are very grateful. Again, I want to thank the organizers and everyone listening. I'm happy to take questions now or by email in the future, and my email address is listed here. I was also asked to mention the National Blood Clot Alliance program and their Stop the Clot, Spread the Word program. Their website has educational tools for both patients and healthcare professionals, and you can visit that. And now I will turn the webinar back over to Dr. Raskob.
Thank you, Dr. Cassidy, very much for that comprehensive and very informative presentation. We now have time for some questions and answers. And so to submit a question, please use the question area of your toolbar. There have been a few coming in, so I'll get us started with those. One question was asking Dr. Cassidy just a little bit more detail on how you reduce the barriers to adoption of your strategies, particularly amongst the other services, but just general overall expanded comment on reducing barriers to adoption of some of these approaches.
That's a great question. The initial reluctance, I think, is a natural response to any change in practice. And what became very important for us was showing the outcomes. And we were able to really demonstrate the effectiveness of the program in our general and vascular surgery patients, and demonstrated a very sustained improvement over time. So that, in the end, was the most convincing feature. And we'd already, at that point, built these systems into our electronic record, and so there was already an institutional familiarity with how the protocol would run and some expertise in doing that. So once the other services finally made the decision that they would like to incorporate into their own patients, it was fairly simple to roll it out.
Great. Thank you. Another question came in just generally about the issue. Are there any situations where you use preoperative administration of antithrombotic treatment?
Yes, we typically do provide a preoperative dose unless there is some contraindication to doing so.
Okay. Just looking now here, how might you be thinking about adjusting this protocol, or is there any adjustment? Is there any role currently, or what do you envision for the direct oral anticoagulants potentially coming into place as alternatives to low molecular weight heparin?
We have not done that to date, and certainly something that we will explore over time in the multidisciplinary VTE prevention group.
Okay. Have you tried any other risk assessment tools than the Caprini Score, or is there a role for others?
The other common one that is discussed in the literature is called the Rogers score. So I think that the valuable part of this is simply to think about each patient's individual risk factors separately from the operation that they're having. So patients even who have minor surgery but who come with extraordinary risk factors for VTE are probably at higher risk for events than a standard patient who's having ambulatory surgery. So it's whatever system is used, it's really intended to have providers be thoughtful about each individual patient that is in front of them. So I think certainly the Caprini system is very well validated over time in a number of populations. So we're confident in its reliability in terms of its ability to predict VTE events. But I think the bigger concept of individualized risk assessment is the important concept.
Great. I like this next question. I think many of us have had experience working with clinical pharmacists. They play important roles in this area in many hospitals. Can you comment to, what might be the role for a clinical pharmacist who wanted to take the lead on trying to get this implemented in their hospital, some of the strategies you've used, or just general comments about how clinical pharmacy can really engage as a profession in VTE prophylaxis in this area?
Oh yes, we have definitely engaged our pharmacy colleagues in this from very early in the planning stages, and they've been instrumental in rolling out the protocol and ensuring that it is successful over time. For our highest risk patients, for example, those in the surgical intensive care unit, the pharmacists actually round with the clinical teams and are involved in making the day-to-day decisions about this type of prophylaxis. And we have actually dedicated anticoagulation pharmacists who help us as well. So they're really an integral part of both the development and the maintenance of these programs.
Great. One individual here is asking, and I think this is an interesting question too, saying that and not designed to pick on any particular surgical specialty, but they've asked about orthopedic and spine surgeries as being particularly resistant to VTE prophylaxis due to concern of risk of bleeding. Also, epidural hematomas. Right. What success have you had implementing it with that group, and any guidance or recommendations, advice you may have?
Yeah, so certainly that's a concern, and it is a judgment call by surgeons to decide how high is the risk of bleeding and how severe are the consequences of bleeding if it is to happen. We have implemented this on the orthopedic and neurosurgery services, although they have been thoughtful about modifications that they have made for their own particular services to make this work for them. So it doesn't have to be the same system for every surgical discipline. There can be modifications made based on the level of bleeding risk and the consequences of bleeding risk. But certainly having a point of departure for those other services has been very helpful.
Good, thank you. As could be appreciated, there's a number of questions here about cost issues, and I guess the question here that I liked was, and maybe this work is ongoing, or have you published, or do you have any data on either doing cost-benefit analysis or cost-effectiveness analysis of these strategies?
So we have not published that to date. We have demonstrated the cost effectiveness of reducing the complications, but we have not formally done the analysis looking at the balance and the cost of the low molecular weight heparin and the extended courses. But we definitely think that reducing the events has led to pretty dramatic cost savings for the hospital.
Okay, great. And here's a very good practical question. Just again to re-emphasize this in terms of assessing individual patients' risk. When do you do that predominantly, and how often? Is there multiple assessments, or is that sort of one time, just close to the time of surgery, or when is that done?
Sure. So most, if not all, of our elective surgery patients are seen in our pre-procedure clinic, and that is staffed primarily by nurse practitioners who perform the initial risk assessment. So they go through all the risk factors listed in the Caprini Score, and they take a good history, and they select all the factors that are present. And then that's carried forward into the perioperative and postoperative period. When patients have their operation, as part of the postoperative order set, the Caprini Score is recalculated, if any, to determine if any of the factors have changed and contributed to a change in the overall score. And then if a major event happens during the hospitalization, the surgery teams know to recalculate the score at that time. And then finally, they do a final check at the time of discharge to make sure nothing has changed. So our surgical health staff and our PAs and everyone on the team really is used to doing this now. So it's pretty much an automatic event that occurs. For the emergency surgery and the trauma patients, they're scored at the time of admission by the surgical health staff, and then again throughout the hospitalization as factors change, and again at discharge.
Great. Lots of very good questions coming in. I think we're going to have time for 2 or 3 more here, but very practical issues. So one of the important areas, and I know that you are very familiar and face this as a surgical oncologist, but the issue of surgery, extensive surgery for cancer in patients and the duration of prophylaxis, not only during the hospital, but post-operatively out of hospital. How are you approaching that? And, and what have you found in just my experience, the one area I particularly worry about are the colorectal people who also, again, along that lines, have some concerns about bleeding. So what strategies are you suggesting there?
Yeah, we in our experience have not had major problems with bleeding events. So as we track these outcomes over time, we're really able to demonstrate that we haven't seen an increased risk of bleeding with extended duration prophylaxis, and that's also true in the clinical trial outcomes. So the bleeding risk seems to be minimal. We find that this is really the value in the Caprini Score and the Caprini System, is being able to calculate a particular patient's risk and give them appropriate prophylaxis. So if the patient is scoring in the low range, we feel comfortable not providing extended prophylaxis, whereas other patients who do score highly on the Caprini protocol, we feel that there is value in the extended prophylaxis. So that helps take some of the more subjective decision-making out of it, and to just go by the risk profile, which helps.
Okay. And for the orthopedic patients, let's say for hip or knee replacement or fractured hip, do you risk stratify these, or are these all at such high risk because of the surgery that there's a fairly uniform approach to these patients?
So it's expected that all the patients will have a score, and certain populations will automatically fall into the higher risk categories.
Okay. Does that risk score influence the choice of prophylaxis, for example, in orthopedic patients, or is that pretty standard?
No, I won't. I can't really speak specifically to the orthopedic surgery patients. I'm not sure what they are doing specifically.
Right. Okay. And I think that that's in flux, and people know there's a very recent paper about longer use of aspirin after just a short course of anticoagulation. So I think we're going to come to our last question, and really here, I think that is a question. What is the role of aspirin, if any, in the populations that you're working with and are familiar with?
So we haven't been using aspirin routinely in the prophylaxis setting. Certainly, as data emerges, we reconsider that. But currently, we're not using aspirin routinely in our prophylaxis protocol.
Okay. Thank you. I think there are, obviously, you stimulated a lot of great interest, Dr. Cassidy, and I think this is very important, timely area. There are many questions. Unfortunately, we've run to the end of our time. I would remind our audience that the webinar will be available again and recorded, and will be available at a time in the future. So you can access that at the archive that's listed on the screen. Dr. Cassidy has been kind enough to provide his email, so I'm sure that he may be willing to answer some questions that you may send. I would like to thank Dr. Cassidy for a terrific webinar presentation today. Do you have any concluding remarks?
I would just thank you again for inviting me to participate.
Terrific. Well, on behalf of the Division of Blood Disorders at CDC, we're really delighted that you could join us to do this. We want to also thank the National Blood Clot Alliance of the United States for hosting today's event, and really appreciate that. Shortly, the participants will receive an email asking for feedback, so please respond with that, because it really helps in improving and planning for future webinars. And if you have any additional questions about today's presentation, please contact Cynthia Sayers at csayers, SAYERS at cdc.gov. Thank you again all for participating, and have a great afternoon.